Hi, everyone. We'll be starting soon. We're just going to give a couple more minutes for everyone to jump on the webinar. All right, good afternoon and thank you for joining us today. We're excited to be with you to discuss the benefits of virtual visits and how to get started using them. Whether or not your organization is currently using virtual visits in any capacity, we hope there will be some helpful takeaways here and we welcome your questions along the way. As we expect, we'll have some time at the end to start answering those. You can send in any questions that you have as we go in the sidebar of the webinar screen.
We'll start quickly with some introductions. My name is Nolan Santosa. I'm the VP of Client Success over here at HRS. We're really excited to share with you some best practices and tips for virtual visits today. I know a lot of the clients on the line, many of you are thinking about PDGM, which is just around the corner. Other people on the line may be thinking about how to start up a new program and incorporate virtual visits into that. And so we're really excited to work with you and give you hopefully some ideas on how to implement that in practice. We also have a guest, one of our clients from Banner Health, Mandy Johnson, on the line. Mandy Johnson, do you want to introduce yourself?
Yes. Hi there, everyone. I'm Mandy Johnson. I am the Care Coordination Post-Acute Senior Manager for Banner Health, our home care department. I oversee our telehealth and our social workers. I have about 2.5 years experience with the telehealth, and I have been in home care for 10 years as a social worker in the field. Thank you so much for inviting me, Nolan.
And my name is Jonathan Kine. I'm an account manager here at HRS. I've been a part of the team for over a year now, and it's been extremely rewarding for me to work with and learn from all different types of stakeholders across the healthcare industry, from patients and caregivers to clinicians and executives. I'm particularly excited by the opportunities to expand patients' access to high-quality care through virtual tools, and look forward to discussing this topic with my great co-hosts today. So we're going to be covering a range of topics relating to virtual care delivery, including what virtual visits are, what they can be used for, how to prepare and launch a virtual visit program, keeping in mind the importance of clinician buy-in and patient experience, and the return on investment that is possible by supplementing in-person at-home care with virtual care. The main goal is for each organization to have some helpful takeaways on virtual visits and to implement into or to refine your current telehealth program.
So to frame the conversation today, we want to start with just talking about what is a virtual visit and really defining those basic terms so we can have a more productive conversation. So in terms of a video visit, what we're referring to here is anytime that you have a clinician who is doing a live video consultation with a patient. The HRS software has this capability. There are other softwares that also offer, the same type of tool. Some of our clients are doing this in a home health setting where the equipment is located in a patient's home and you're doing a consultation with them from the office, from the road, wherever that clinician is located. Other clients who use this may be using it in a clinic setting where you have a tool available there to do a consultation from that clinic to a remote healthcare professional. So there's a lot of different ways that this can be incorporated. And I think for a lot of the people that are on this webinar, you're thinking more about that patient in their home setting, how to reach that patient in their home, doing a virtual visit with a healthcare professional. One important distinction that I want to make here, and we're going to talk about this throughout the webinar, is the difference between scheduled virtual visits and as-needed virtual visits. So those are two different types of visits that can happen. The scheduled ones are scheduled check-ins that happen with a patient, as in, hey, let's have a check-in tomorrow at 11 a.m. to see how you're doing, where you're going through kind of a basic assessment. That's one type of video visit that we see commonly. The other type is as-needed virtual visits, or PRN virtual visits, where you're doing a virtual visit in response to a patient calling in or a patient having an elevated blood pressure. And those are both different ways that this technology can be incorporated that we're going to talk about today. So before we dive into talking about how you can actually implement this, some of you may be thinking, well, why would I actually want to do this, right? What is the why for the patients? What's the why for the clinicians? And that's really what we're going to dive into here next. A lot of these are pretty straightforward and things that a lot of you have thought about already or maybe even have implemented. As far as the patient perspective, really the goal here with using virtual visits is to be able to improve the patient care. And a lot of that has to do with reducing patient anxiety. We see in a lot of instances that patients who are at home, they may start to become anxious because they don't have that healthcare professional that they had when they were in the hospital right next to them or when they were in a facility. And so being at home can be a little scary when you don't have a healthcare professional right there, but having somebody available at the tips of your fingers where you can just click a button and be face-to-face talking with a healthcare provider, that's huge for a lot of patients, and it allows them to feel more comfortable in a home setting and reduce the patient anxiety that they might have. I want to share quickly two stories of virtual visits that we've had and kind of give you an idea of how patients can really benefit from them. One of them is from a client that we work with, Cornerstone VNA, that some of you may have heard of. And what they've done is they've been incorporating virtual visits into their workflow for a long time. One of my favorite stories is from a telehealth nurse, Annie Carl, and what she had was a patient who had called into her frantically because that patient had spilled their daily medications all over the floor and they weren't sure which medications to take. So what Annie was able to do was jump on a video call, actually physically see the medications and help calm the patient down by helping them put the medications back into the right pill bottles and be able to make sure that they took the right medications for that dosage period and make sure a nurse was out there soon to help them with the rest of their medication. So that's a way where that patient was really anxious and she was able to calm them down really quickly. And we hear stories like this all the time of patients who have oxygen tubes or medication instruction that can be done over the virtual visit. So there's a lot of great ways to use that. Another patient benefit is just more access to clinicians and specialists, being able to touch base quickly, not just with the nurse, but with social work, with physical therapy, with the caregiver even. There's a lot of ways that they can get more access to those people than they'd be able to in person. And I think the other piece is just having more immediate follow-up when those clinical issues do occur. So what we quoted on here and what you're seeing on the slide is actually a study that talked a little bit about how these virtual visits actually impact patient care. And one of the misconceptions is that Virtual visits will never be as impactful as in-office visits. And there's truth to that. They're always different. But what this study found, and this was published in the American Journal of Managed Care, is that with the virtual visits, 62% of patients actually reported care quality was equal to the in-office visits, and 21% actually reported it was even better. And I think the key thing also is the increased patient convenience. And this study also found that 79% of patients actually had an easier time scheduling the follow-up visits through there. And for those of you who are doing home health or even a setting where the patients have to drive to a clinic, having the ability to speak with that patient immediately through that video conferencing function without having that have them drive to a clinic or wait till the next nursing visit, that's a huge increase to the patient convenience. And so in general, what we've really found with the video visits is that they do improve those relationships with clinicians, they do increase patient satisfaction, and patients overall will have a better experience and better care when they have this incorporated into their workflow. So next, we're going to talk about the clinician side of things. So from the clinician standpoint, what are the benefits that the clinicians are going to see if they start doing video visits, right? I think one of the important things to talk about here is that the video visits for a lot of organizations, it's a little bit scary, right? You're thinking, well, in-person care is how we've always done things. This is the best way to deliver care that we've found. It's how we got our outcomes. And really the goal with virtual visits is to augment the in-person visits. It's not always to supplement, to replace the in-person visits that you have, right? It's to supplement, it's to augment what you're already doing. We've heard stories from clients where they'll actually do an in-person visit with a nurse, and maybe they want to consult a wound specialist. So they'll actually do a video visit from the patient home to bring that person in, right? Now we're augmenting the in-person visits that are happening, delivering better care to those patients, and also speeding up the process at which you can get resolutions. It also broadens the access to care because it allows a social worker that might be able to drive out and see 4 patients to now use the video visit functionality to see 12 to 20 patients in a day and do a lot more appointments than they were able to do beforehand. So it really broadens that access to care, especially for some of those remote patients, the ones that are furthest away in your service area that you might have. And it also provides user-friendly communication. It's a way to develop relationships with your patients beyond the in-person visits or the clinic visits that you might have, and really strengthen that bond, really develop that trust between the two, the clinician and the patient, and be able to have that easy access to be able to speak with them right away and get answers. And from an organization perspective, there's many ROI benefits for your return on investment in using the telehealth program, right? You have patients that are less likely to go to the emergency room or to urgent care when they have something come up. They can just do a video visit with a clinician. They're less likely to get readmitted because you can intervene with them quickly. It's also possible to improve your efficiency by potentially decreasing skilled nursing visits or decreasing other visits that clinicians might be doing and decreasing that drive time. And it also improves your clinical interventions. It allows you to intervene quicker, as we mentioned, on some of those issues that might come up. And I think the last piece that sometimes gets neglected is that video visits are a big selling point for you as a program. If you have this virtual component, that makes patients more likely to join your program, to participate, to want to continue to have a relationship with your organization after the end of their enrollment on their program, and maybe even continue to stay in the network of your organization long term. So it's really a great benefit to do that, as well as to get other partners, whether that's a physician group, a payer, involved in your program and getting them excited about what you're offering to your patients.
So we've begun to touch on the concept of virtual care at a high level and the many benefits that it can provide to all types of stakeholders, from the patient themselves to clinicians, all the way up to the financially minded leadership of the healthcare organization. And this is a topic that we'll dive into in more depth a little later on. That's all great, but the question soon becomes, what are the practical steps necessary to put this idea into practice? There are a few important pieces for an organization to consider and address before being able to effectively take advantage of a video conferencing platform as a way to deliver care to patients. At this time, I would like to bring our attention to some common obstacles and how to overcome them. The first topic to consider here is the functionality of the video conferencing platform itself, specifically making sure that the organization is well prepared to place and receive video calls to and from patients. It is more than likely that an organization will be using a video call platform specifically designed for healthcare delivery, whether that be one that is built into the remote patient monitoring software provided by HRS, that of another telehealth vendor, or a more video call-centric solution. When partnering with any third party, the first and most obvious step is to share all relevant documentation on system specifications provided by the vendor with your IT team in order to prepare your devices for the video visit strategy. There will likely be a brief period necessary to tweak those devices' settings, potentially with some trial and error during the setup phase. The sooner that this work can begin, ideally several weeks in advance of the intended virtual visit's launch, the more likely the kinks can be to be worked out to ensure a smooth rollout. To efficiently tackle this process, a healthcare organization will want to take advantage of the opportunity to work with the vendor's technical support team to test video call functionality and gain insights on best practices and recommended workflows before reaching the point when real patients are introduced into the mix, and continuing as needed after video visits have begun to be incorporated into your care delivery. As many of us who use FaceTime, Skype, etc. already know, while the technology is rapidly becoming more stable and reliable than it was just a few years ago, there may still be variables in the setup affecting call connectivity or quality. Therefore, it is a good idea to anticipate that the workflows that clinicians use and locations where clinicians and patients are initiating or receiving video calls may need to be refined and adjusted over time based on experience. This includes identifying where the clinician and patient get optimal signal reception in their respective settings. Aside from the technical preparation, it is understandable that some clinical staff may be unfamiliar with how virtual visits should be incorporated into patient care. When this capability has not previously been available to field staff and specialists, there is often a clinical perception shift that must occur when virtual visits are being implemented. And this is even more so the case for scheduled virtual visits as opposed to those only conducted on an as-needed basis, a topic that Nolan had briefly touched on and a distinction we'll soon discuss further. To make clinicians feel more comfortable conducting virtual visits, consider strategies such as providing them with a video visit script or, to a less structured degree, a tip sheet that highlights the main points to hit on in each virtual visit throughout the patient's enrollment, which can be developed in coordination with your telehealth vendor. On this important topic of clinician buy-in, there is often a preconceived notion that older patients who are previously unfamiliar with this technology unanimously will not want to do this. As Nolan discussed earlier, studies do not back this up, nor does the vast majority of experiences among HRS clients who do perform virtual visits. While some patients, regardless of age, may refuse virtual care, research indicates that most patients who are introduced to virtual visits embrace and frequently prefer them to in-person visits due to an increase in convenience that does not negatively impact the quality of care being delivered to them. And Mandy, I remember you having some insight into this topic as well. I remember you mentioning a 92-year-old patient. Would you mind elaborating on that if that rings a bell for you?
Yes, Jonathan, that is true. I agree with that quote about the 68% of patients being happy with the virtual visits. I have seen that in person with our population. We had a 92-year-old individual in one of our locations that actually completed the complete pathway and did about 4 video visits with their clinician. They were very excited and they enjoyed the fact that they were able to do that. I also have another patient who was 87, and as my social worker explained, he was very nervous, but once he was able to complete that call, the smile on his face when he was able to see the person on the other side face to face through a tablet, he just lit up, and he talked about it for the rest of the day. He was so excited he was able to do something, and he was able to brag about it.
That's great. So as you can see here, on the one hand, there is this element of eliminating false notions of patient age being a barrier to conducting visits virtually. Another critical element of ensuring clinician buy-in is to not only provide them the tools for how to perform virtual visits that help guide those who might be hesitant to embrace this new method of care delivery, but to clarify why exactly the organization is implementing this strategy and why their participation on this level is so important. So before the first video call is ever initiated, clinician buy-in really starts with a clear communication of the benefits to both the patients and the clinicians themselves. Typically, a top-down approach in which the clinical manager is introduced to the plan before the field staff become involved is best. Any managerial reluctance can be addressed by having clear pathways and providing time for those clinical managers to give it a try and come back with any concerns after their trial runs. This process will also be driven by general awareness among the staff of the financial benefits to the organization as they relate to PDGM preparedness, cost avoidance in reduced travel time and associated expenses, and increased productivity and capacity to provide the same high-quality care to more patients. Those clinical managers can even get creative in incentivizing their clinical staff to utilize virtual visits through a structured, friendly competition between direct colleagues or between offices. And Mandy, would you mind sharing how you incentivize the use of virtual visits at Banner Health?
Yes. So it's very important, especially at the beginning, that you incentivize your staff. You have to get their buy-in. You have to encourage them to try something different. You got to remember that this is new. This is not the way things have been, and it's going to be difficult. It's going to be different. And making sure that they understand that, but encouraging them and giving them a reward for doing it. So I like to make sure that we value their time. What is their productivity? So I like to give a 2-for-1 in their productivity, especially when starting out, because they're going to be concerned. They want to try something different. So if I reward them, they're going to have that buy-in as well. Once they get used to the process, then that can be reevaluated. I like to also show them, as far as the windshield time, how it actually makes their job better. So if we can show that we're thinking about them and we are putting objects into place that's going to make their system better, they will also have that buy-in. So pointing that out about, wow, you saved 30 minutes of your day. Think about how much more that you could do to help another patient, or you are actually able to check on that patient more than you would have because you're not having to drive to all these different places. So I like to point that out. So some of the things that we've done here at Banner to kind of tell you what we've done, what we've gone through, how we've implemented things, so you can bring that back to your own organization and see what will work. Have different takeaways from what I've worked out and gone through the system. So we've been doing video visits for about 2 years now. One of the ways that we do is we actually have those scheduled visits that Jonathan and Nolan have mentioned on. I find this process works well. I like to make sure that it gets on the calendar and it's on a set frequency. So that's been part of our pathways. As I'm sure many of you guys are developing for PDGM, pathways are kind of your evidence-based practice, your care that's being provided on a set basis. So what we do there is we want to make sure they're reviewing symptoms. So in between those in-person visits, we have those video visits. It's that check-in. How are you doing? Have there been any changes? So they're a little shorter than your in-person visits, but it's kind of that review, providing that additional education. Because sometimes when you're in the home, you've given them a lot of information and it's a lot to process. When you go back the next time, you go over what you did, but maybe you have other tasks that you have to focus on. So what this allows is that extra education that you can touch. Do you have any questions? Did you read over that diabetic information? How is your wound doing? Do you have any questions about your therapy? So it's that great touch base in between those visits. We have also done a proactive MSW visit with the telehealth. What that means is we know these patients that are often on telehealth or remote patient monitoring have chronic conditions. They're going to be on and off services. So what I've done is I have an MSW call every patient through a video call that is on telehealth. And what the point of that call is to talk about long-term planning. How are you doing right now? Are there any additional needs that you might have? So having that discussion about future needs allows them to think about other things. So that's kind of our proactive MSW approach. That's different. It also allows me to be able to touch a lot more patients without sending my social workers all over the United States. We have definitely had some great clinician and client experience. As I mentioned earlier about the 92-year-old. My older patients really love the video visits. So I always say, give it a try. And even the clinicians who were like, oh, they'll never call. I'm like, try it. Do one visit and then come back to me. And they actually find that it's easier. So just walking through them, setting with them the first time. What I like to do for the patients is show them in the home. Because if you just call them and say, I'm going to call you on your tablet, there's a button that says answer, they're a little concerned. So what we do is we know when that video visit is going to be. So the week before, we show them, we do a call to them, the nurse right there in the home to the patient, and they can actually walk through that process. So they're more comfortable. The other thing I like to do is make sure it's scheduled, and then we call the patient to confirm, to make sure they're by their tablet, make sure they didn't forget. The point of that is we often forget our own appointments. So just having that call beforehand is going to make it more successful. So that's really important, and it's make sure everyone is prepared, because as we know, things can happen. We could be eating, we could be in the bathroom. So making sure you call beforehand, and then that's going to set yourself up for more success with that virtual visit.
Thank you for all that, Mandy. And as everyone who's in attendance can see, we're really lucky to have a resident expert with Mandy Johnson on the line with us. So, Mandy, I'm going to pick your brain a little bit on kind of the next few slides and just kind of talk together about enhancing the clinical workflow. So, you know, Mandy gave a really nice roadmap on how to actually implement virtual visits with your organization. And what we want to kind of explore is, how do you maximize these? What are the different ways that you can incorporate them? What does the future have? You know, a lot of you, like we mentioned, are thinking about PDGM. What is that going to look like? If you're not a home health organization, what are other ways you can incorporate these? Those are all things we're going to kind of look at over the next few slides. So one of the distinctions that we want to talk about is scheduled versus as needed, which I mentioned earlier. And just to recap this piece, the PRN visits are the ones that are unscheduled. You know, something comes up. There's really two different ways that PRN visits can come in. One of them is by a patient request. I'd call it an active request, where they either call in or they text in and they ask, hey, you know, I have this symptom, or report something, right? The other way that you can get that communication is passively, where a patient is recording metrics. They record something on RPM. Maybe it's an elevated weight, an elevated blood pressure, and because of that, you initiate a video call with them to say, hey, let's chat about that. What's going on? Answer questions, perform interventions like I mentioned earlier with the medications, things of those nature. The other way is with scheduled visits. And so this is where the care pathways that Mandy mentioned comes in, where you're actually scheduling out throughout the episode, or if it's not home health, throughout their enrollment on telehealth. How often are we doing virtual visits? Who are those virtual visits with? And where do you kind of go from there? And so these are sort of the two different ways that you can incorporate them. A lot of organizations have asked me, where do we start? Where's a good way to kind of get our feet wet in terms of virtual visits? And what I usually recommend is, I think PRN visits, I kind of think of them as the low-hanging fruit. That's an easy way where you can have your centralized telehealth staff, if you have them, or even the clinicians out in the field, just start trying out the virtual visits and seeing how they work and using them in kind of the context that makes sense. The scheduled visits involve teaching everyone a care pathway, which is really important and just takes a little bit more legwork in terms of getting that clinician buy-in, because you have to go to all those different clinicians who are going to be doing those virtual visits. So really the answer is they're both important. PRN can be a good way to start, but as long as you're kind of thinking about the long-term vision of how you're going to incorporate both of these into your workflow, I think that's a really good way to get these incorporated. So Mandy, a quick question for you, if you can share a little bit of guidance. From your side, do you currently do PRN visits? And if so, what are some of the things that you would advise your staff to look for in terms of when they should actually be incorporating those PRN visits into their workflow?
That is one area that we have not really used at this time. So we don't use the PRNs. We focus more on that schedule, but I can definitely see how that could be a benefit. I've really considered adding in those PRN to our triage team. When a patient calls in with a concern, that they could actually assess them face-to-face over the tablet before we send somebody out. So that is definitely on my radar in the future. But with our current setup, I have not been able to fully implement those PRN visits as I would like.
Mm-hmm. And I know with the care pathways, you've done some really great work with your CHF pathway, and now even expanding into new conditions. So when you put those together, you kind of have those regular check-ins. How do you teach your staff as far as what they should go through? Do you have kind of a rubric with questions, and they kind of go question by question to ask the patient about those? What does the actual context of that call look like?
Yeah, so we did start with CHF, and I set those on a frequency. So one of the biggest things that I really like about that is I kind of do a test drive. So we want to keep the patient on longer, and this way we can check in. How are you going to do without us? We kind of do every other visit as a in-home visit, and then the following weeks a check-in. I don't write out an exact script for the nurses. The reason I don't do that is because I find that they would only ask what is on there. So I try to make them more comfortable because it's something new. So I give them the list of symptoms to review, not necessarily specific things to ask. And making sure they're on the schedule. The reason I did the scheduled visits is just to make sure they don't get missed. And as we're getting that buy-in, it makes sure they actually get done. So that's kind of why I went with that scheduled process.
I think that makes a lot of sense, and I know that's one of the things that some organizations worry about is, how much do we have to script this out and how much should we have in writing? And I think the approach that you mentioned is what we've heard from other clients and sounds like is working really well for Banner, which is you don't want to script it out too much. You want it to still feel like a natural conversation, but you want to give them some guidance as far as how they want to talk about those things. I think the other thing to mention with the care pathways is a lot of you are probably thinking about PDGM and knowing that the LUPA requirements are going to change, our visit frequencies are going to change, maybe reduction isn't actually good for us in the new year. And what I would respond to there is that we know that a lot is going to change with PDGM. What is going to set organizations up for success is increased flexibility, the ability to do more or less visits for each patient depending on what's allowable under the PDGM requirements for that specific mix of patients as far as their diagnosis and where the referral came from. So being able to incorporate these into your care pathways as Banner has done really gives you a nice position to be able to take advantage and really thrive under PDGM. So the next thing to talk about is how to incorporate specialists. And one of the reasons that we wanted to have Mandy as our guest on this is because she's done such an amazing job incorporating her social workers, which is really a unique model and one that I think a lot of other organizations should look at and kind of consider. Another big specialist that a lot of organizations are talking about, especially with PDGM coming, is physical therapy. How do we incorporate physical therapy and maximize those visits, especially in the second payment period, the second set of 30 days, where there's going to be a little bit less reimbursement during that time period? What I always think with the specialists is that really the virtual visits should solve a problem for you. So where are you limited in capacity? Where do you have limited staff resources where you're not able to get out to all the patients that you want to? You're not able to visit the patients as frequently as you'd like, and apply the resources that way, whether that's social work, PT, speech therapy, dietitian, whatever specialist that you have, maximize those resources and come up with ways to really get them to be able to reach as many patients as possible. So Mandy, I know you've worked with the social workers in your kind of strategic vision for Banner and kind of where you see this going next. Are there other specialists that you're thinking about incorporating into your workflows for virtual visits?
Yeah, so we just recently started using our dietitian to have video visits. This is a great way when a patient has wounds, maybe be on tube feeding. So our dietitian is in the office and she is able to actually do those video calls to the patient to do some of that nutrition education. She was previously doing them over the phone. This way, she's actually able to have that face-to-face with that patient and make sure they're understanding the information. So that's something new we recently started. We also, with our sepsis pathway, are using PTs to do the video visits just to kind of check in on those sepsis symptoms if they're having any reinfection that's going on. So we have just recently started that within the last month with both of those areas.
Those are all really great applications for this. And the other thing I wanted to mention quickly for our audience is that HRS does have the ability to do three-way video calls. So in a lot of circumstances, we've seen clients where maybe the nurse is doing or the telehealth nurse is doing the initial video visit and having them potentially loop in one of those specialists, whether it's a dietitian or a social worker or a PT. So there's lots of ways you can mix and match this to really maximize those resources and be able to provide patients easy access to some of these specialists that they might need to speak with. One of the other considerations that a lot of organizations have is how to make the patients feel most comfortable with doing a video visit. And in that comes with how to set up a call booth. So really what is a safe and comfortable location for both the patient and the clinician to feel like they have the ability to have a private conversation about the patient's needs and their medical condition. And so we've seen a lot of different models. Some of the more common ones we've seen, one is a central station where you have your telehealth team all working from. So they have, a setup where they have a desktop computer, a webcam, a headset, and kind of a comfortable environment behind them where they can really sit there and speak one-on-one with the patient privately about their condition. The other one is for the field clinicians, right? So sometimes field clinicians are doing these video visits. Maybe it's for a consult, maybe it's scheduled where they might be out in the field, in their car, and other locations. And certainly we want to provide flexibility, but it's also important to think about what will make this patient feel comfortable when I'm speaking to them. And one thing that has worked well is having a self-serve setup at a clinical desk or a station somewhere in the office where, if somebody needs a little bit more privacy to do a video call like this, they can actually go in there and submit the call from there. So there's a lot of different ways to set this up. I think the important thing is mindfulness and just thinking about what will make the best experience for the patient and make them feel really comfortable with this. So Mandy, from your side, what are some of the ways that you've helped your staff with this, and what are some of the considerations you have when thinking about how to set up for a video call from a clinician standpoint?
One of the things that I have my staff do is test prior. So I have a test kit. My tele RNs have the availability to test as well. So they want to be comfortable before they start. So I make sure all the clinicians, before they go out to do one with the patient, have made a test call so that they're comfortable with that. Most of ours do it from the field. One of the things that I mentioned is making sure they have connectivity. So if they're in one area that may not get as good reception, they probably shouldn't do the video call in that location. Some of the nurses and my social workers usually do them from home. So they have a little place set up. I make sure they test their headset to make sure they have good interface, that it works. So you want to do all that before you do it with a client. So that's the biggest thing about setting it up for success, is making sure you give your clinicians all the equipment that they need to be successful.
Absolutely. I think those are great points, and I think it ties in nicely to what we're going to talk about on the next slide, which is some of the best practices that we've seen. And one of the big ones that we see with a lot of organizations is setting up testing sessions and encouraging staff to ask questions about doing it, right? The patients feel comfortable when the staff feel comfortable, and so giving your clinicians an opportunity to try those calls out, to get a feel for what it's like to do a virtual visit, it may be new for both of them, especially for the field clinician. So it's important that everyone on both sides feels comfortable with the new setup, and having a testing session like you mentioned, or a testing kit available, is a really important best practice that we often talk about. I think for clinical best practices in terms of rolling this type of program out, our recommendation to an organization doing this, brand new, starting from scratch, never done virtual visits before, one is just determine what's the location where we're going to do these. Is it going to be a centralized clinician in the office? Is it going to be field staff? Kind of get a feel for who needs to be involved with it, and then set up these testing sessions for them so they can really get comfortable with it. Once you have your staff up to speed, you want to start small. So rolling out the virtual visits to a small cohort. Mandy gave a great example earlier about how she started with CHF first, starting on that one disease group, and then expanding it from there to other diseases. That's a really nice way to start into things. And she also started just with the scheduled visits, not with the PRN also. So introduce few variables, start it off small, get a feel for how it's going to work. And then from there, you can really, once you've proven out the model, you've proven that clinicians will buy in, it'll be much easier to expand it to larger populations. I also think, and this is one of the things we talked about, was creating documentation resource materials. So coming up with some kind of script or outline that will give your clinicians direction in terms of how to actually do a virtual visit. What should I talk about? Is there a recommended way to introduce myself? How should I end the call? Are there any considerations I should have while I'm doing it? All those types of things. And also take advantage of your telehealth vendor. HRS, from our side, we've developed a lot of materials to help our clients with best practices for virtual visits, sample scripts, sample documentation. These are all things that you can get from us, where we can really help you get that started on your program. So hopefully all these tips will kind of give you some ideas about where you can go if you want to start a brand new program. And Mandy, we want to thank you for all your feedback there as well. I'm going to switch it back over to John now, who's going to talk a little bit about telehealth etiquette.
So far we've discussed some practical steps that you can take in preparation for a smooth rollout of virtual visits. Now we'd like to switch gears and discuss some points to consider towards ensuring a high quality experience for the patient during a virtual visit. While this is a different method of care delivery than traditional models, the same preparation steps should be taken before each virtual visit. This entails reviewing all of the same records that you would in preparation for an in-person assessment, including previous clinical notes and biometric readings, the patient's medication regimen, and medical history. Furthermore, to whichever extent it's applicable given your organization's current digital tools and resources, it's a good idea to review any electronic correspondence that might have taken place with that patient. For example, the text messaging feature that is available through the HRS platform, as well as any symptom survey responses that the patient might have given via telehealth. Before being able to leverage virtual visits in any capacity, whether as needed or on a more scheduled assessment basis, it is crucial that telehealth patients know the steps of how to participate in a virtual visit, as well as the reasons for when and why they can expect this tool to be used. A best practice that we have seen at HRS is to conclude the equipment installation visit with a video call to the patient, either initiated by the installing staff member while in a separate room of the patient's home or by a centralized office staff member. This step allows the patient to know what it feels like to be involved in a virtual visit, as well as learn any necessary steps to receive the call right from the start of their telehealth enrollment. Under ideal circumstances, this installation visit is conducted while a caregiver is also present, so that he or she can receive the same instructions as the patient and help reduce any anxiety the patient might have about learning a new system. Another best practice to implement for any scheduled virtual visits is to contact the patient a day or two before the scheduled virtual visit is set to occur, either by phone or by text message, to confirm the time and discuss any important information that the patient needs to be aware of in advance. For PRN virtual visits, contacting the patient by phone first to make sure the patient is comfortable proceeding with and is appropriately prepared for the video call is a simple step to help ensure an optimal experience for both the patient and the clinician. So just like in traditional home healthcare delivery, an organization's patient satisfaction scores often benefit when there is a continuity of care throughout a patient's telehealth enrollment. When the same clinician is conducting those virtual visits as opposed to various staff members, the patient can more easily feel that he or she is really getting to know the patient and vice versa. Of course, it is to be expected that a patient will engage with multiple clinicians when a specialist is being incorporated into a patient's virtual care, but otherwise it is worthwhile to consider a program structure that allows each patient to interact with the same clinician throughout his or her enrollment. When this is not possible, as in the case of a coverage situation, it is a good idea to let the patient know that a different clinician will be involved in advance of their next visit, which should also be conducted with the same high standards as the patient's previous virtual and in-person visits. There are plenty of other best practices that can help ensure a positive patient experience, many of which might be intuitive but are worth a quick mention. This includes such simple steps as being mindful of the patient's time before the virtual visit is expected to start and communicating with that patient as appropriate, especially in the case of a delay on the clinician's end, such as if you're running late from a previous assessment. Maintaining eye contact through the virtual visit, periodically checking to make sure that the patient can see and hear the clinician, and clarifying any actions that the clinician is performing during the video visit, such as pulling up the patient's chart or performing any clinical documentation. We at HRS have developed a quick tip guide to performing virtual visits that hits on these points in more depth, which you should have access to now as a handout on this webinar. It is a good practice to conclude each virtual visit by getting the patient's feedback on his or her experience and anything they feel could be improved, as well as to clarify what next steps the patient should expect moving forward in his or her enrollment, including scheduling the next assessment and other appointments they should be aware of if applicable. These steps can help ensure that the patient feels their best interests are being kept front and center through this shift in care delivery. As we reviewed, virtual visits are a critical element in connecting with patients post-discharge, extending high-quality care conveniently, incorporating specialists, and overall reducing hospital admissions or readmissions and ED visits. The application of virtual visits into patient care plans, both scheduled and as needed, have a substantial impact on cost avoidance for patients and healthcare agencies. To drive home the cost effectiveness of virtual visits, we would like to review some recent studies. All these studies will be made available following the webinar. The first study I'll be referencing here is a study that Jefferson Health recently conducted evaluating the cost effectiveness of on-demand virtual visits performed as an alternative to emergency care. Research at Jefferson noted what each patient would have done had virtual visits not been made available to them and compared the cost of care between the options to establish estimated cost avoidance. Overall cost avoidance to patients and payers was between $19 and $121 per visit. The most expensive alternative to virtual visits were ED visits, and each ED visit avoidance resulted in cost avoidance of $309 to more than $1,500. Kingston Health Sciences Center implemented a 6-month pilot program to evaluate the feasibility of virtual visits to provide follow-up care to stroke patients. The pilot focused primarily on clinical workflow, patient satisfaction, and out-of-pocket cost avoidance. During the pilot, 40% of follow-up visits were virtual, and patient satisfaction remained exceptional. However, visit time was reduced due to efficiency, and family member attendance was increased with 60% of patients having a family member attend a virtual visit with them. Intermountain Health evaluated claims data over a 1-year period, comparing virtual, ED, urgent care, and PCP visits, grouping by diagnosis and comparing episodes of care. Each episode of care included initial visits with a provider and any subsequent medical care, lab, and prescription charges. Across 7 of the 9 conditions, cost of care was significantly reduced for virtual visits compared with ED, UC, and even PCP visits.
So what are the key takeaways here? Our hope is that you come out of this webinar thinking about a few different things. One is that virtual visits are not replacing in-person visits entirely. They're meant to be supplemental. They're meant to add to what you're doing to enhance patient care. And there's a lot of different ways to incorporate them. Our hope is that you'll also think about what is the optimal clinician-patient experience, knowing that virtual visits really can make a positive impact, and being mindful of some of the different ways that you can make it as positive an experience as possible for both of them. I think the other takeaway is that knowing that, as evidenced by Mandy and her team at Banner and other HRS clients, with the right support, it isn't too difficult to implement virtual visits. It can be done. You can overcome the barriers. And we're here to help you with that and guide you through every step of the way and avoid some of the pitfalls that you might have. And lastly, as shown by John, there are major financial benefits for this. There's huge cost avoidance. We've seen it with our HRS clients, as you've probably seen on many of our press releases. We've also seen it in the clinical research as John just went through. So there's a lot of ways that this can really make a positive impact to your ROI and help make your telehealth program more financially viable and more scalable for the long term and help you really reach those strategic goals that you have. So we're going to dive into questions, but before we do that, if any of you do have to jump, we want to thank you so much for attending today. We hope this was really beneficial for you. Please do reach out to us. We have additional studies and resources available at the website that's listed here. You can also reach out directly to John or myself, as well as whichever HRS reps that you're currently talking to, and we're happy to talk more and open a dialogue about virtual visits. So with that, please take a moment, submit some questions to us. For those of you who have submitted questions throughout the webinar, we're going to review those now, and we look forward to answering some of those. And if you have to jump, please feel free to submit us questions offline, and we'll reach out directly to you as well. So just give us 1 minute here. We're going to review a few of the questions, and then we'll go through them together. So one of the questions that we got was, how do your RNs, care managers, or installation teams calm patients down who are worried about the security of video visits? So this is a good question. It's something that comes up from time to time. We've heard clients who have patients who are worried about, can you see me all the time with the camera that's on there? Will you be able to hear what I'm doing? Worried about, other people being able to see them in their home. And the reality is that, from our side, everything's encrypted. There's no security risk. And I think the important thing to stress to the patients is that this is a way for them to have more interaction with their nurse. Everybody wants more time with their nurse. Everybody wants more time with their clinicians. And this is a way for them to easily access it. Once the call's over, the interaction's ended, we're not spying on them or anything like that, and really just make them feel comfortable with the whole situation. Mandy, from your side, have you ever had instances where patients felt really uncomfortable with the idea of video visits, and do you have any recommendations on how to calm them down?
Yes, that comes up quite a bit, especially with technology. A lot of the hacking, they have questions and concerns, and it's important to listen to those concerns and talk them through the process. That's why I like to do that test call in their home to show them what it's going to look like, to show them that they have the choice to answer or ignore. That makes them feel more comfortable letting them know that they have power over accepting that call or not.
I think that's an important point, having the option to answer or ignore, and that gives them empowers them to be able to choose. And if they're not ready, if their still need to get dressed, they can always hit ignore and not take the video call at that time. We do have another question that just came in about how do you recommend contacting patients prior to a video call? Is it text messaging? Is it phone call? Is it scheduling it? What have you found most successful? I know from the HRS side, most of the clients that I speak with are still doing a landline phone call to the patient first before doing a video call. So they'll call them, they'll say, hey, are you still ready to do that video call? If so, go over to the tablet, I'll give you a call momentarily. That's really the method that patients are most used to receiving communication through. So it's a good way to make them comfortable and kind of not surprise them with a video call all of a sudden. Mandy, I think you mentioned this earlier as well, but is that what you found also in terms of getting patients ready for a video call?
Yes, I find that to be the most successful method. That way they are by the tablet, because sometimes we don't want them running through the house and falling on their way to get to the tablet to get to that call. So it just kind of sets that visit up for more success by making that phone call. Are you ready? Do you have any other questions? So you can kind of walk them through that comfort level additionally before making that call as well.
Absolutely. We did just get another question that came in. This question is asking about how does doing virtual visits with the centralized telehealth team impact our staffing ratios? Will we have to hire more nurses? Which is a really interesting question, because a lot of organizations who are doing remote patient monitoring with their centralized team, if those nurses aren't currently doing virtual visits, obviously this adds significant time to their day to be able to do these. What we typically recommend, and what I've seen work pretty well for this, is if you have that centralized team not doing as many of the scheduled visits, but focusing mostly on the PRN visits, oftentimes the centralized team is already calling the patients when they see an elevated blood pressure or a weight gain. They're calling the patients on their landline. So if you're already calling the patient to talk about what symptoms you're seeing, why not just do a video visit with them? So that way you can still have that same conversation, but you get to see physically how they're doing and what they physically look like. Are they looking exhausted? Do they look like they may need to go to the hospital? Is their oxygen tube unplugged and maybe that's why their oxygen level has been decreasing? Are they taking their medications properly? There's so much that you can see on that video call that will really make it much more impactful than just doing a phone call. And it also helps develop the relationship with them. So my answer is it really shouldn't impact your staffing ratio that much if you're focusing on PRN visits. And that's how most organizations will use their centralized teams when it comes to the virtual visit component.
And we may have time for one more question here. It looks like it might be a quick one for you, Mandy. Someone asked, you mentioned starting with CHF patients for virtual visits. Is there a particular reason you started with that patient population?
Yes, so that's a population that has a lot of frequent rehospitalizations. They go in and out of the hospital. They're often on and off services. So this was an area that I really wanted to focus some education with the patients on, some consistency. So with that pathway, I kind of did a lot of different virtual options with it. So the video visits being one of those, some of the videos that are incorporated in the HRS technology to help increase that education. I felt strongly about that population because of the fact that they have a significant cost to the company, and it was most essential to start with that.
That's great, Mandy. Unfortunately, we are reaching the end of the hour, so I want to stop here. I know there's a lot of other questions, and we are definitely going to reach out to you individually afterwards to make sure you get your questions answered. I do want to thank everyone so much for your time. We know you're really busy, and so appreciate you taking an hour out of your day to spend with us and talk a little bit about virtual visits. We hope this was a beneficial presentation. We also want to thank Mandy, our co-host, for lending her expertise and best practices. And if you do want to reach out to us, please don't hesitate to continue the conversation with us after the webinar is over. Thanks so much, everyone, and have a great rest of your day.